Welcome everyone to the SAB's June educational webinar, Updates in Bronchial Thermoplasty, a concise review of literature. Before we get started, a few housekeeping items for everyone. You all have joined in a listen-only mode. Please ask questions throughout this webinar by using the question feature located on your control panel. We will address all of them at the end of the lecture. Dr. Ahmad is the SAB Chair of the Education and Program Committee, and he will be our moderator this evening and introducing tonight's speaker. Dr. Ahmad?
Hi everyone, thank you for joining us. It's my pleasure today to introduce Dr. Hasnain Bawaadam and welcome him to the SAB webinar. Dr. Bawaadam is actually one of our members of the Education Committee, so it is with great pleasure that we welcome him today. Just some background on Dr. Bawaadam. He's actually an interventional pulmonologist and intensivist at Advocate Aurora Medical Center at Kenosha, Wisconsin. He's a director for the Pulmonary and Respiratory Care Services and the Intensive Care Unit there. He's also the co-director for the Interventional Pulmonary Program. He did his medical schooling at Grand Medical College in University of Mumbai in 2002. And then completed his internal medicine residency at West Suburban Medical Center in Chicago. He did his pulmonary medicine fellowship at Chicago Medical School and did his critical care fellowship at St. Louis University in Missouri. After completing his pulmonary and critical care fellowships, Dr. Bawaadam worked as a pulmonary critical care attending at Advocate Aurora Medical Center in Kenosha for approximately 6 years. He then took a year to attend his interventional pulmonology fellowship at the University of California at San Francisco. He's an active member of the ACCP, AABIP, and obviously the SAB. So it's my great pleasure and honor to welcome Dr. Bawaadam. Dr. Bawaadam.
Thank you, Danish. Thank you for the kind words and the welcome. And hello, everybody. We're going to talk about study updates in bronchial thermoplasty, a review of literature over the last 12 plus years that we've had that is pretty robust, now pointing towards more and more usage of bronchial thermoplasty for especially for severe refractory asthma. I'm going to share my screen here. Is my screen visible, Danish?
Yes, it is.
Thank you. A little disclosure here, speaker with Intuitive Surgical. So, characteristics of asthma. There's a triad everyone knows of is the airway inflammation, airway obstruction, and hyperresponsiveness, irritability of airways, and mucus production. So what happens during an asthma episode? During an asthma episode, the muscles around the airways tighten up, linings of the airways, the bronchioles become inflamed, mucus clogs the airways, and breathing gets more and more difficult. So this is a very classic picture known over many textbooks, which show the normal bronchiole on the left and an asthmatic hyperinflamed bronchiole that constricts and causes difficulty breathing, wheezing, coughing, chest tightness, etc. Continued exposure and or lack of treating the inflammation will result in hypoxia, O2-CO2 exchange abnormalities, and untreated, this inflammation can cause recurrent episodes of wheezing, coughing, and potentially causing airway remodeling. What are some of the contributors known to poor asthma control? We all know about environmental exposures, the allergens, irritants, the comorbidities, sinusitis and GERD play number 1 and number 2, followed by obesity. Improper technique, non-compliance, or not knowing the exact method of using inhalers, the cost and access to healthcare. The initial Gina stepwise from the National Asthma Education and Prevention Program that showed the 6-step approach where we tier up or step up. And this is the modified one that came out later that shows a step 1 to step 6, starting with pure and short-acting inhalers, and then slowly moving up the steps. And it's generally at step 4 and step 5 when you start thinking of adding biologics, the anti-IgEs, the IL-5s, IL-4, 13s, and it's generally at step 6 when you've actually exhausted all your resources and moved towards bronchial thermoplasty discussion. What is the asthma yardstick model? This is a model where the controller treatment is either adjusted upward or downward. And I find this very interesting because strategies for stepping up controller therapies are very well described and known to many. In the adult and pediatric asthma yardsticks provide excellent recommendations based on patient profiles, right? But the strategies for stepping down controller treatments are less and less clear. Although stepping down to the minimum effective therapy is important, crucial. And when someone's controlled well on their inhaler regimen for about 6 to 8 weeks, generally 2 months, is when one should consider stepping down on their inhaler regimens or their biologics. So background, what's with this airway smooth muscle that we all know that bronchial thermoplasty targets? So we all know that worldwide asthma affects close to 250 million people worldwide, and in the United States it affects about 25 million people. 5 to 10% approximately of whom suffer from severe persistent symptoms and contribute to the majority of healthcare utilization associated with this disease. The higher risk of death, comorbidities, very costly. Airway smooth muscle cells proliferate around the bronchioles faster in asthmatics than non-asthmatics, leads to increase in their smooth muscle mass with airway narrowing. And that increase in airway smooth muscle closely related to the airway hyperresponsiveness, and that distinguishes the severe from the moderate asthma. So enter bronchial thermoplasty. So FDA approved this in 2010. Our premise is to reduce the airway smooth muscle mass. It entails 3 procedures done via flexible bronchoscopy, each done 3 weeks apart. And all the accessible airways which are distal to the main stem bronchus, that are 3 to 10 millimeters in diameter, are treated, except for the right middle lobe, which was left out in the initial study due to risk of right middle lobe syndrome or stenosis. And it shows here the healthy airway at the bottom left with the normal airway and normal airway smooth muscle caliber. Then progressing with asthma and severe asthma, you see the maroon smooth muscle layer getting more and more thicker, and that's excessive smooth muscle. And then when you have an asthma attack, it constricts and causes narrowing of the airway. And then you see on the extreme right diagram that you have post-BT, where the airway smooth muscle is narrowed again. It reduces the muscle mass. And it's not just the muscle mass that translates into the improvement in your asthma, but also the downstream effects of the airways that are less than 3 millimeters below it. And several ex vivo human studies have shown that it's reduction in the airway smooth muscle more than 50–75% that translates into your improved ACQ and AQLQ scores by downstream airway improvement beyond the 3 millimeters. And how do we know that BT reduces the smooth muscle? This was a good study then. 17 patients with severe asthma that underwent biopsies pre-BT and approximately 3 to 8 weeks post-BT. And they saw that there was a reduction in the airway smooth muscle mass. And as you see here on the left, you have dense smooth muscle mass, all of that taken at biopsies in the pink striations. And then you see on the right, much reduced. And how was this taken? So this picture, the A on the left is at visit 1. That's done from the left lower lobe when the patient comes in for the right lower lobe treatment of bronchial thermoplasty. So that's pre-BT on the left lower lobe. And then visit 2 you'll see the reduction where visit 2 is from the right lower lobe that was treated in the last session, that treated at visit 1. And you see the reduction in the pink mass. So reduction in exacerbations and improved asthma control. And then came the asthma term study. It was a French trial, and most patients were on the GINA 4 step already. There were about 40 patients included here. They studied them by Pritolani and group. That showed the effectiveness of bronchial thermoplasty in patients with severe asthma. Now, this was a very carefully designed study. Why? Because it showed BT downregulates your selectively the structural abnormalities involved in the airway narrowing and the bronchial reactivity, particularly the airway smooth muscles, the neuroendocrine epithelial cells, and the bronchial nerve endings. And BT significantly improved asthma control and quality of life at both 3 and 12 months and reduced the number of severe exacerbations. Actually, the mean dose of oral steroids was reduced at 12 months. You see here the outcomes 1 year post-BT. Besides the reduction in the airway smooth muscle by 73%, there's reduction in severe exacerbations, ER visits, hospitalizations, all significant. Improvement in your ACQ or ACT scores, your AQ-LQ scores. And the higher the ACQ scores, the worse it is. The lower the AQ-LQ scores, the worse it is. Worse your control of asthma. And it showed reduction of your mean oral corticosteroid doses, but no change in FEV1s. So significant correlation between reduction in ASM and improved clinical outcome. This was the study done by the Pritolani group. So how do you explain BT to your patients? So BT is a system, and before I get into all the studies, the robust evidence that we have, I want to talk a little bit about BT for the sake of the audience as to how it is and how it's done. Delivered by the LS system, CFR procedure, spread over 3 sessions, right lower lobe, followed 3 weeks later by the left lower lobe, followed 3 weeks later by both upper lobes. And you clearly see here the normal patient increased airway smooth muscle, and then the treated airway with reduced airway smooth muscle mass. And I always talk about establishing a BT center when you're starting a BT program as having 4 components. This was taught to me by my program director at UCSF. He always talks about the bronchoscopist as the woman or the man, the plan, the clan, and the fan. So how do you select your patients? You review available literature with your patients and set very realistic expectations that you're not going to see a difference during treatment. You may not even see a difference immediately after your treatment. It may not be there for several months. Review appropriate studies before selecting your patient, your PFTs and your MCTs, your methacholine challenge testing. You treat any GERD that's there, or even sinusitis, because unless that's treated, you're not going to have a robust outcome. And you evaluate and treat your barriers for asthma control, your technique, your compliance, the environment in which the patient's living, allergens, etc., and access to healthcare and the cost for the patient. There's a little checklist for your BT appropriateness. Do you have a documented diagnosis of asthma? Yes, check mark. You have recent chest imaging, chest X-ray or CT scan. Is patient medically managed at least at step 4 of the chart of the GINA? Patient has severe asthma per ATS-ERS definition, meds have been reviewed, and I always talk about addressing comorbidities, sinusitis and GERD being the most common. And then you check your blood count, your differentials, your IgE levels, if done within the 3 months, biologics were done or not, and your ACT scores generally more than 19. Some of the contraindications, not all of them are absolute here, but some of the contraindications that I always talk about are patients that have a pacemaker, internal defibrillator, other implantable electronic devices would not qualify. Patients that have known sensitivity to medications, either moderate sedation or general anesthesia for doing the procedure would not qualify. Relatively, again, patients that have previously been treated with the LS system and didn't respond or had some other adverse outcome, less than 18-year-old, have not been tested or trialed, patients are current smoker, inability to differentiate between a clear asthmatic or asthmatic bronchitis overlap, and more than 3 lower respiratory tract infections in the last 12 months, or life-threatening asthma in the last 24 months. So the inclusion criteria, if you're generally at or above 50%, Th2 low, polygranulocytic response best, because if you have Th2 high, you want to try your biologics first. And of course, declines, fails as contraindication to biologics in your Th2 high atopic population, high IgE, IL-5, and other relevant forms of asthma. So the precautions you want to take: to treat any active respiratory infections, postpone your procedure if you have to until you're done with that. Any asthma attack, or changing the dose of the steroids, up or down titration done in the last 14 days, patient receiving increased boosters, known bleeding disorder, high bleeding risk, INR more than 1.5, a patient unable to stop taking anticoagulants. Because yes, hemoptysis is a respiratory adverse outcome seen with multiple trials during the course of the study. So, we see this all the time when we're actually doing the procedure: mild hemoptysis, self-discontinued, self-stopping, self-limited, but does happen. And then next we go to the plan stage. You have all the equipment needed. You have the tech, the same tech performing PFTs pre and post for a given patient, even the same day morning spirometry before the procedure. Your anesthesia considerations and pre-procedure orders. Safely able to undergo the bronchoscopy, so no active infections. I keep harping on this, but within the last 2 weeks, no asthma attacks requiring up or down titration of your steroids, no recent significant increase in your rescue meds. And you actually want to give prophylactic oral corticosteroids to all these patients before your BT procedure. So 3 days prior, you give them the 50 milligram dose each day. On the day of the morning, the 50 milligram, or you can give them IV Solumedrol, and the day after the procedure. You do spirometry, as I said, the morning of to assess stability and to measure how much it's post-procedure, where you discharge them home. And you prepare for outpatient bronchoscopy procedure, local anesthesia, moderate, general, whatever your institutional preferences. So that's the ALAIR system, which is comprised of the ALAIR catheter on the left and the ALAIR radio frequency controller. And the catheter is basically a device. It's a single-use disposable device with an expandable wire and an electrode array at the tip to deliver the monopolar therapeutic radio frequency energy to the airways, and by a very standard flexible bronchoscope. So the ALAIR radio frequency controller, which you see on your right, supplies this radio frequency energy to the catheter, and the controller is designed with it's a set proprietary set of controller parameters and algorithms that safely delivers a certain temperature and accurately delivers the intensity and duration of the energy that's needed to reduce this airway smooth muscle tissue. And again, this energy is very proprietarily, algorithmically safe and designated or designed to limit long-term impact to surrounding tissues. We say deploy when the prongs come out and the prongs touch the airway walls, as you see here on the bottom left, and applies the heat energy, which is about targeted temperature of 65 degrees centigrade to reduce the mass. And these wire legs are 5 millimeter exposure are by these black beads on it. And there's a set way to do this. You say deploy, your technician deploys, the airways come out, they approximate on the bronchial walls, and then you deliver the set temperature, after which you say release, and then they go back to its initial position again in the non-deployed position. And I show here my program director, Dr. Krishna, who actually was the first one to perform this procedure on the West Coast in California. Boston Scientific actually bought Asthmax that created the ALAIR catheter first, and that's how Boston Scientific now owns the ALAIR catheter device. It's a little video. That's the catheter coming down. And then as I said, the device comes out. And that's the energy being given. And so that showed exactly how the procedure is done. And I'd like to show this video here. This is a canine model. It's pretty neat. You're actually applying methacholine to both, and then one of the airways on the right is treated with radiofrequency catheter. Now, the LR treated or the BT treated. So the BT treated airway on the left, it remains open, as you see here, after methacholine installation, while the right actually gets constricted, representing what would actually happen during a severe exacerbation, because that's what methacholine challenges, right? You give methacholine to constrict, to cause bronchoconstriction. I could just play this again here. And that's your right and left. The left is treated with bronchial thermoplasty, and then when you insert methacholine to both, and then your right reacts because not treated with BT, but your left is not. And then you come to the BT clan. You have one assistant, very much needed to document exactly which airways you've done, which RB or LB branches or sub-branches you've already tackled. One tech for documentation, and a very uniform method to do this. Procedure 1 is always the right lower lobe, followed by procedure, great netto diagram here. Procedure 2, 3 weeks later for the left lower lobe, and then 3 weeks later, finally both upper lobes. And you actually have to put the activations or how many burns did you actually give to the airways. And the uniform method is so that you target all the airways from 3 to 10, and you don't miss out any airways. And there's a method to the madness here, and you go distal to proximal and lateral to medial. Always distal to proximal, lateral to medial, so you know you've covered all the branches and sub-branches. So now let's dig into the evidence and why do we say that yes, BT should be offered to patients. The ATS-ERS 2014 guidelines that came out, the recommendation placed higher value on avoiding adverse effects. So, and that's why they stressed that only in the context of institutional review board approval, approved independent systemic registries was this recommended. So the quality of evidence was very low, although the strength was strong. The next came the National Asthma Education Prevention Program 2020 guidelines. The recommendation rationale was the benefits were small, the risk was moderate, and honestly, long-term outcomes were uncertain. But some patients were willing to accept the risks, so can choose whether they want to do BT, but BT shouldn't be part of routine asthma care, is what they said. Why conditional recommendation, right? Strength of recommendation, it says conditional. Because for patients, most individuals in the situation would want the suggested course of action, right? But many would not. And for clinicians, different choices will be appropriate for individuals consistent with their values and preferences. So shared decision-making is what we come into. So decision aids may be useful in helping those individuals make these decisions. And the certainty of evidence is low because our confidence in the effect estimate is very limited. And the true effect may be substantially different from the estimate of the effect. So again, suggestions for safe use were FEV1 more than 50, as we said, age more than 18, used in registry or clinical trial to track safety and effectiveness, experienced specialists or centers only, and optimize all asthma regimen and comorbidities always to be treated. So here we jump into the trials, right? 3 of them were multi-center randomized trials, and then the 4th one was sham control, which was the AIR2 trial. The first one was in 2006. At the bottom here, we look at the feasibility study. It was a single-arm prospective study. It was done to evaluate the safety in patients with mild to severe asthma. The mean FEV1 was about 82% in that group. BT was very well tolerated. Only mild adverse events were noted that resolved spontaneously or when meds were increased. There was significant reduction in the airway hyperresponsiveness even 2 years after BT. What I mean by that is you needed higher methacholine concentrations to provoke the same PC20 drop on the methacholine challenge test. So the peak expiratory flow improved, more symptom-free days, but there were no changes in FEV1 at 2 years. We then moved to the AIR trial. Now, what is the AIR trial? This was a study that came out in 2000 and published in 2007. BT versus usual care or standard of care, right? The AIR or the asthma intervention research study, this had 112 patients there. FEV1s were about 60 to 85% in those patients. They took away the LABAs post-treatment at certain time intervals for 2 weeks during 3, 6, and 9 months. There was no changes in the pre-bronchodilate FEV1s or the responsiveness. But BT patients, better asthma symptoms, both AQLQ and the ACQ scores, and symptom-free days, milder asthma exacerbations, and increased morning peak flows. So basically, what did this show us? The AIR trial that came out in 2007 told us that although there were no deaths, the BT arm had more adverse events than expected, right? But mostly comprising of a transient worsening, not a whole lot sustained. But a major limitation of the study was what? There was a lack of the control arm or sham arm, right? It wasn't a blinded study, as we see here. We then moved to PAVOD, a 2007 RESA trial. The RESA acronym stands for Research in Severe Asthma. Now this came out in 2007 again. Randomized trial, sorry about that. That was again a clinical trial of 32 patients, and they all had severe asthma. Very similar in design to the AIR trial that we had, but it just had patients who were more severe with the FEV1s. The FEV1s were about 60 to 85% in the AIR trial. This was done by the Coxon group. I take that back. The RESA was the PAVOD trial in 2007. These patients were on ICS and LABA. They also were plus and minus prednisone, and they were followed for 1 year. The ACQ and the AQLQ improvements, they did persist, but the study was not blinded again. So there was content that there was probably some placebo effect here. And although the reported efficacy of the BT was put in question because of the absence of the sham in the study, this study did unequivocally demonstrate that BT could be performed in patients suffering from severe asthma with a very acceptable safety profile. So all 3 studies did show transient worsening of your asthma symptoms, the feasibility, your AIR, and your RESA. And this happened during the first 6 to 8 weeks following BT. Then came the landmark study. There was the AIR trial. That AIR 2 talk about in a second. So the AIR 2 trial. What was the AIR 2 trial? The AIR 2 trial was a randomized control trial, double-blinded, and sham control here. 30 sites, 6 countries, and started sometime around 2005 and went on till 2008. There were 3 bronchs done. Each was done 3 weeks apart. And this is the inclusion criteria. So people inhale corticosteroids and LABA. Pre-bronchodilate FEV1s were more than 60%. Baseline AQLQs were less than 6.25. Non-smoker for a year, at least 2 days of asthma symptoms. This is the exclusion criteria. And this is self-explanatory. What I want to focus on here is that the sham arm protocol, but use these sham radiofrequency controllers. So basically the other arm, which was not the BT, arm, they got the same radio frequency with the same alert cathode signals from the. Am I audible? Danish, am I audible?
You keep cutting in and out.
Sorry about that. Am I audible now, Danish?
Yes, it's better.
So the duration of the sham and the BT were matched. This basically gives you that all the patients pretty much have at the same baseline characteristics in the BT and the sham group. Very well matched, and most of them had severe and inadequately controlled asthma. So what does this show you? This shows that the baseline AQLQ was 4.3 for both groups. Now, more of the BT than sham had the minimally clinical difference in your AQLQ, which is more than 0.5, but 63% of the shams still had improvement. Why? Huge placebo effect. And it's a known issue with asthma interventions, right? Subjective endpoints are prone to huge placebo effects. But what is the thing that came out of this? BT responders had lower baseline AQLQs and higher ACQ scores than the non-responders in this trial. That means the BT responders had worse asthma than the BT non-responders. And that was important to note. And the possible explanation for the sham placebo effect could be that the sham radiofrequency controller along with the flex bronch could have probably just removed all the mucus plugs mechanically, thereby improving asthma. What did the study show? There was 32% reduction in severe exacerbations, 84% reduction in your ED visits, 73% drop in hospitalizations, more than 2 days reduction in lost days from school and work, and no significant non-significant changes in your morning peak flow symptom-free days and rescue med use. Again, both groups experience respiratory adverse events. 85% of the BT patients and 76% of the sham patients still had respiratory events. And it's hard to imagine that, right? Because 76% of the sham patients had adverse events just from what? A flex bronch. Here are some of the distributions of what the adverse events were in this trial. 2 patients in the sham group required hospitalizations for worsening of the asthma. So the final conclusions of the AIR2 trial, 32% reduction in asthma exacerbations, 84% reduction in ER visits, and was supported with 5 years of data, and the data came out 5 years later. I'm going to talk about it in just a minute. And this was a 3-year follow-up in the AIR trial. Results, no difference between the BT and standard of care in year 3. Although there was improved methacholine PC20 doubling in the BT group versus the sham group. And why did I include the basic AIR as a 3-year follow-up? I did that because it actually compares your long-term follow-up data between BT and control group. Albeit it's not a sham group, but still a standard of care control. And the results, admittedly, were a bit of a letdown. So take-home message from the AIR 3-year follow-up. This is not the AIR 2, mind you. It's the AIR trial, the initial AIR trial published in 2007 with a 3-year follow-up that the group looked at. No huge advantage of BT over standard of care at 3-year follow-up, but no long-term adverse events from BT. Then you had the AIR 2 5-year follow-up. Now, this study was exclusively followed up for those patients in the AIR 2 cohort. They were unblinded by now, of course, and they underwent BT either during or after the AIR 2 study. And what did they do? They compared basically each subject's own baseline with the year immediately preceding the BT. So before they got the BT, how did you feel and how did you feel after the BT? And then they followed it up for 5 years. And what did it show? Reduced rates of severe exacerbation, reduced hospitalizations, reduced ED visits. All of them continued to be reduced for 5 years following BT. Also, a high-res CT scan was done 5 years post-BT that demonstrated no clinically significant structural abnormalities following BT. So take-home message, BT reduces exacerbations, ED visits, 5 years. That's pretty robust evidence here. All your ICS dosing with no long-term adverse events, but unclear if any better than sham. Some of the controversies and concerns were, it doesn't reach the smaller airways. So how do you think it affects? Because you're doing it only for 3 to 10 millimeter airways. And distal airways make up about 10% of the total airway resistance in a normal person, right? And BT is only from 3 to 10. So could you be missing a major site for airway obstruction in asthmatics? So the reason is there is downstream effect from reducing ASM mass. Also, there is some explanation of disruption of your nerve endings in your autonomic nervous system, because not only are you seeing distal effects, but you also see effects in your right middle lobe, which is never treated, which actually tells you a pretty much hand-wavy explanation of your nerve disruptions, and your neuroendocrine cells are also affected distally to the treated airways. That overall improves your asthma control in all lobes, in all segments and subsegments. Patient selection, I like to mention this, is were they really severe asthmatics? Where 50% patients reduced ICS, right, by about half. So many of them are over-treating with your inhaled corticosteroids. There was lack of a run-in time to verify that these patients are truly high-dose ICS dependents. A 2 AQLQ difference was about 0.19 between the two groups, and it didn't quite achieve statistical or clinical significance. As I said, it needed to be 0.5 of MCID, minimal clinically significant difference in your AQLQ, to say it was significant. And no long-term data for the sham arm. So 3 big trials again, your AIR trial in 2007, your research trial, research in severe asthma in 2007, and then your AIR2 trial. So your systematic reviews from all 3 trials showed no long-term decline in FEV1, no change in ED visits, reduction in frequency of respiratory events. Then came your BT10 that I'm going to, the observational international multi-center observational study that I'm going to talk in a second. But before that, I would like to talk about the PAS2 study. What is PAS2 study? That's an open label, prospective multi-center study that was done to confirm the efficacy when performed in clinical practice. What does PAS stand for? It's the performs the post FDA approval clinical trial evaluating bronchial thermoplasty in FDA approval clinical trial evaluating your BT in severe persistent asthma. The results were published in the first 190 patients who were compared in a PAS study at 3-year follow-up, and compared them to the 190 subjects from the A2 post-BT. The only difference that the PAS2 patients were on an average a little older. They had some higher BMIs, higher inhaled corticosteroids, and they reported higher rates of severe exacerbations. While the initial treatment period saw a higher rate of exacerbations and ED visits amongst the PAS2 cohorts, no difference was noted in the rates of respiratory events in the subsequent follow-ups. What does that tell you? It tells me that BT reduced severe exacerbations, hospitalizations, again, ED visits, average daily ICS use, OCS use, oral corticosteroid use, no effect on spirometry, more events during the treatment period, and no deaths related to BT. That was a big concern in the 8 to 15 era Were there deaths related? What was the long-term outcome? Take-home message: BT reduces exacerbations, hospitalizations, ED visits. Your inhaled and oral corticosteroid use in real-world practice with no long-term adverse effects, but unclear if any better than sham again. This is the BTGR, the Bronchial Thermoplasty Global Registry. It was again a 2-year real-world follow-up data, open-label, prospective, multi-center study done. The results showed BT reduced severe exacerbations, hospitalizations, ED visits, ICS, OCS use, biologic use, so improved quality of life, no effect on spirometry, and no deaths related to BT. Take-home message: reduces severe exacerbations, hospitalizations, ED visits. The BTGR was done by the Torrigo group in Spain. It's across Spain. It was 18 centers. It was across Spain and Italy, Germany, UK, Netherlands, Australia, and they enrolled people from 14 to 16. Everybody was severe asthma. The only drawback was it was an industry-sponsored study. The thing about this study is when patients were asked at the end of their 2 years or 24 months if they would want to undergo BT again, and if they would recommend BT to a friend or a family member, 87.3% patients said yes, they would undergo BT again. It helped them. And 94.9% of subjects said yes, they would recommend BT to a friend or a family member. So that's vital. This was a small study done at UCSF by my attendings just prior to my fellowship. A short study, N25, prospective single center study done, 1-year follow-up. The primary outcome was change in your mini AQLQs 1 year after BT. And the secondary outcome was your change in your asthma med use 1 year after BT. They did a mini AQLQ, which was comprised of lesser questions than your big AQLQ or the larger AQLQ, which is like 30 or 32 questions. The inclusion-exclusion criteria was pretty much very similar to your AIR2, except that most severe asthma patients were included in this. No oral corticosteroids of more than 10 milligrams or more than 4 asthma exacerbations. What did the results show? The results showed that BT improved your mini AQLQs 3.6 versus 5.6 and statistically significant. 88% showed clinically significant improvement at 1 year. BT also reduced your Singular or your Montelukast use and your omalizumab or your Xolair use for 1 year after BT, both significant. The only non-significant thing was the reduction in your oral corticosteroid use. Next, comparing BT with biologics. The Langton study, it was a single center study done. It was done out of Australia. The patient characteristics were mean ACQs were about 3.5 plus or minus 0.5 or 1. It was a prospective observational study for 1 year, severe asthmatics, BT in 44 patients versus mepolizumab. Why mepolizumab? Because that was the only thing available and a funded drug that was funded in Australia at that time. BT was done under general anesthesia and patients were admitted for 24 hours for observation. Most of them got 3 sessions and some of them got compressed sessions, which is 2 sessions. What are the results of this study? The results of the Langton study was the ACQ improved, exacerbation rates reduced, inhaler reliever inhaler use reduced, FEV1 improved, 160 compared to 150. And the readmissions, the prolonged admissions reduced at 6 months. And 25% of the mepolizumab patients had discontinued the treatment at 12 months. The next study that I want to talk about is the Manzella study that came out in 2021 out of Italian group. There were 2 referral centers here in Italy. There's a retrospective observational study done for 1 year, severe asthma. 30 patients underwent BT, benvelizumab for 32 patients, Xolair or omalizumab for 54, and mepolizumab in 83 patients. The BT patients were actually the ones ineligible for the biologics based on their IgE and EOs, or they didn't respond to biologics or refused biologics, one of the above. What are the results? No adverse events throughout treatment period. Seems too good to be true, but it did happen. Take-home message, BT is just as good as biologics in severe asthma. Of course, cost effectiveness, BT is cost effective in the US, where procedure costs are low and hospitalization or ED costs are high, but not in some of the other countries, or like Singapore, where cost procedures are high, vice versa. In the US, there's more than 60% chance that BT is more cost effective than Xolair or standard of therapy. As we've looked at some of the cost analysis studies that have been done. In Japan, BT is cost effective in responders, second to reduced hospitalization and ED visits again, and discontinuation of biologics completely, but not cost effective in non-responders. Biologics, pretty much done. The pros, not of the procedure, less scary for patients. And the cons, high cost, longitudinal therapy, non-compliance. It doesn't typically work in the Th2 low, the low HOP, low IgE, low EO population. Could work, but does not work, and it's not going to be approved. Also, we don't exactly know when can biologics be discontinued or stopped, right? None of us would know when to exactly say now you go off of it. We could try 2 or 3 months, but no one knows this is the end of it. On the other hand, BT, the pros are works well in the Th2 low inflammation, asthmatics. The cons are respiratory events during the treatment period, the 0 to 6, better than the sham, and insurance often doesn't cover it. You got to do prior auth, you have to have your nurse or your office staff keep calling, and finally they may approve it, or you write a letter to the Senate. This came out in Lancet in 2021. The BT10, the safety and effectiveness of bronchial thermoplasty after 10 years in patients with severe persistent asthma. There's a follow-up of the 3 randomized control trials, pretty much investigating the efficacy and the safety of the bronchial thermoplasty after 10 or more years. That's a pretty solid longitudinal follow-up. The multi-center international follow-up study, previously all patients were enrolled in AIR, RESA, or the AIR2 trials. So the cohort made up of all these trials, patients taken from these, were 10 or more years of follow-up after BT. Only participants in the AIR2 trial had CT scans prior to BT. Again, the primary effective endpoint was durability of BT, right? Reduced ED hospitalization, ER visits, hospitalizations, etc. And the primary safety endpoint was absence of clinically significant post-treatment image changes after BT, like bronchiectasis or stenosis. So BT stent study enrolled about 192 patients, about half of the participants of the previous 3 big trials. 136 patients received BT, while 56 in the control arm, and about a third of the patients in the control arm received BT again once the original trials concluded. The baseline characteristics, we're going to skip through that in the interest of time here. But what does this show you? Results. This is comparing. The last line here shows how it compares to year 1, 2, 3, 4, 5, and this is year 12 months prior to BT for events for severe asthma, ED visits, and admissions for asthma. And you see this, although not statistically significantly different at year 10, it shows a little reduction at 10 years during 12 months prior. In ED visits, also it's significant because of the asterisk mark here. It's reduced significantly compared to 12 months prior and reduced, but a sustained effect from year 1 to year 10. Also, admissions for asthma reduced from 12 months prior to year BT10. Also, every successive year, admissions for asthma were reduced and followed up for 10 years. So reductions in asthma exacerbations, ED visits were sustained at 10 years. There was improvement in quality of life sustained at 10 years, no effect on sobriety, no deaths related. 7 participants did have some bronchiectasis, but none clinically significant. Take-home message of the BT10, benefits were sustained at 10 years. This is pretty robust evidence, safe and unclear if any better control than sham control. Again, these are 2 big score lines that we check, right? The ACQ score and the AQLQ score. The lower the AQLQ, the worse off the person is. And you started off low, and then you baseline 12 weeks, 6 months, 1 year, and the BT10. And you significantly see that it's improved. Your AQLQ scores are improved where you want it to be at 10. So the patient's AQLQ score, which is a memory recall based on your symptoms, had improved. And your ACQ scores, again, 12 weeks, 6 months, year, and the 10-year mark had reduced, saying that yes, your symptoms were better controlled. Again, so BT10-year follow-up showed reduced admissions for asthma, 5-year effect sustained at 10 years. The sham-only group reduced admissions for asthma, 1-year effect sustained at 10 years. Then study show you there could have been a potential selection and recollection bias. Again, AQLQ is based on memory, 2 weeks prior, how they answered your questions. Study funded by Boston Scientific. 3 of the authors of the BT10 were employees with the Boston Scientific. There had been a bias. But BT, robust, you saw the reduction in the asthma exacerbations, asthma visits, ER visits, durable past 10 years, and has an acceptable safety profile. BT should be offered to patients who have failed medical management to include biologicals. I'd like to mention of this bronchial thermoplasty in asthma, looking at the endophenotypes. This came out in respiratory research, again in 2021. Prospective single-center study of 30 patients who underwent BT and had endobronchial biopsies and before and after 3 sequential BT sessions, 5 each session. Patients were classified based on blood EOs, atopy, allergy, and smoking exposure. Tissue sections were sent for histopathology. It's looking at expression of the HSP, the heat shock protein 67, receptors, proliferating cells, Ki67, that stains for those. And the beautiful Venn diagram that shows different endophenotype and the overlap that we see in our clinic practice too, between EOs and atopy, smoking and the allergy group, or the atopy and the smoking group. There were patients who were high or lows, EOs, atopy versus no atopy, based on the IgE count and allergy without allergy testing. In all patients in the study, BT improved asthma control, your ACQ, ACT scores, reduced airway smooth muscle, and improved your proliferative Ki67 positive staining cells. In all patients, BT increased the expression of your glucocorticoid receptors in the epithelial cells and the expression of the heat shock 70 and 90 proteins. What does this mean? That means they had upregulation of their steroid receptors. So that means the patients had a better response. So if they use it even once a day, it saturate all the up receptors and have a better response to your glucocorticoids. And this was important. And across this types, BT caused a significant reduction in airway smooth muscle mass, especially in your atopy, allergy, high asthma phenotypes. In conclusion, BT leads to a reduction in your airway smooth muscle, epithelial regeneration, increased expression of your glucocorticoid reception and your heat shock protein. They're different amongst different phenotypes. Of course, the response is best in the T2 highs. In conclusion, favorable effects of BT are durable, as we saw in the BT10, up to 10 years with an acceptable safety profile. They did have bronchiectasis seen, but only a radiological finding, not so much of a clinical finding. And the exact mechanism of action is still not fully understood. Take-home points, last slide here, before I talk about a few interesting cases. Bronchial thermoplasty sustainably reduces your exacerbations, ED visits, hospitalization without long-term adverse events, short-term transiently during the period only, unclear if any better than sham, BT just as good as biologics, as we saw many studies that I showed you, more cost effective, and try BT in severe asthmatics, severe refractory asthma, if patients willing to accept short-term risks. Some of the case studies, first one showing ASM targeted high IgE, and then shared decision making. A world-class NBA player, 31-year-old asthma since childhood, on and off meds since 8 to 13, grew up in Arizona, moved to New York, moved to Texas, both on Advair, Sabas, Nebs, steroids, all of the above. Did BT in 2020, right lower lobe that had 91 activations, left lower lobe 66 and 117 in the upper. Quite a number of activations done, targeting very small airways. No adverse events related to 3 treatments. He credits his success to BT, helping him get back to his game and prolong his NBA career. 2 years out, still seeing benefits, no exacerbations. Second case, high IgE. 30-year-old female, asthma for many years, intubated twice, ICU admissions per year, high dose of everything, tried Xolair, without exacerbation, was using a rescue albuterol Saba many times. Chronic steroids, prednisone 5 mg per day. Again, many activations, right lower lobe, BT session, 90 activations, left lower lobe, 72, and the upper lobe, after activations of 122. Outcome 2 years, within 2 months, patient reported breathing was much better pre-procedure. Still in Xolair for allergic symptoms, but no hospitalizations. And she states not needed a steroid burst for a severe flare-up since doing BT. Her quotation, I would say, for me, BT was life-changing. My quality of life has skyrocketed. And the last one is a story of triplets we treated. 66-year-old severe asthmatic, asthma since childhood, 1 of 3, 2 had asthma, 1 had mild. We treated one of them with right lower lobe, 70 activations, 77 left lower lobe, and 101 in both upper lobes. Hiatal hernia-related exacerbations were corrected after the repair. Outcome, positive about the results, recommended it to her sister who also got BT. And her asthma was under control. She was able to get the surgery for the hernia that further helped her breathing and her overall symptomatology. None of this would be possible without my family. So going through my fellowship after years of being an advocate Aurora, moving with me with a 6-month-old child to San Francisco. That's my wife, that's my 6-year-old On, and my 2-year-old Jude. Thank you, guys.
Thanks, Dr. Bawaadam. That was great. Really in-depth review of the literature, especially the most up-to-date information that we have available. So I think everyone learned a lot. I know I did. I did have a couple of questions coming in. I was wondering if we could go over them. One of the questions we had was about shared decision making that you mentioned. We reviewed all this data talking about the complexity of the benefits of BT and the exact patient phenotype, that endophenotype that benefits from it. How do you speak with the patient when you're discussing BT with them?
So I talk about BT as being, I don't talk about it as being the last modality. It's the first thing, because that's discouraging to a patient that you have nothing after that, and would you go to BT or save it for another day? I talk about BT at kind of GINA step 3 or 4, try and incorporate that. And I'm seeing that they're using more and more medications. I try and talk to them about doing this procedure, show them a little video, and tell them that this is what would entail. This is the symptomatology expected during the BT sessions. It's a long commitment of at least 2 or 3 months out, and benefits would be seen 3 months, 6 months out of your procedure. And if we don't have that, we could still go back to continuing with your biologics or your asthma medications. So that's where I talk about shared decision making, where the patient's involved, shown videos, shown literature, and you always want to pick up patients who've met criteria and are appropriate to undergo BT.
The other question that I saw was, you did mention your last patient was on Xolair and received BT. Is there something that you have done often, or have you seen a lot of data on patients being on biologics and then receiving BT as well?
I have, and it's always okay to try BT on patients who are always on biologics as well. I have done that for allergic atopic kind of patients who've been on it for a year and a half, and they've tried missing a few doses coming off of it, but have not succeeded. They've been, quite disappointed that they're now going to be able to get off Xolair. Decision making and say, why don't we try doing bronchial thermoplasty and seeing if that works? And I was able to actually get 2 patients off their biologics by doing bronchial thermoplasty.
That's wonderful. I think that's goes to your point about the longitudinal management of severe asthma on biologics with longitudinal long-term care. And it's very interesting to think about that you're able to get a couple of patients off their biologics with the use of BT. I don't see any other questions. I think we're running out of time as well, so I want to take the opportunity to thank you again for an excellent webinar and for sharing your time and expertise with us.
Thank you guys for listening. Thank you for inviting me, Danish. Thank you, SAB, for inviting me for this.
Take care. Have a good night.
Thank you everyone for joining tonight's
Good evening.
webinar, and we look forward to more educational webinars with the SAB. Thank you. Good night.